morning. It is really great to be here with all of you. As mentioned, I'm Sarah Singleton. I'm principal at Levitt Partners, which is part of the HMA family of companies. We're sort of the arm that works on the federal policy environment. So our opening plenary today, we're going to talk about what's happening, and I thought I would stage set for just a couple of minutes about federal policy in 2025, which I think everyone in this room is probably paying attention to. So first, kind of how did we get here, where we are at the end of September 2025? Once the election happened, it was pretty clear that there was going to be a partisan path this year. That's due to the dynamics of how the U.S. Congress works and the fact that if you have a supermajority, if you have the administration and both houses of Congress controlled by one party, they have a particular set of legislative tools they can use that rely on just votes from the majority party. So knowing that that was going to be the option, we sort of knew that this was going to be a partisan year, and of course it did turn out that way up to now. 2024, it wasn't a healthcare election. Those of you that have been around for healthcare for a long time, you remember after the Affordable Care Act passed, the next midterm cycle, it was, repeal or defend the ACA, and that was one of the big topics. That was not the case this year. So there was some hope that maybe healthcare would be off the table and other issues would be in play, but it sort of became inevitable. You kind of can't take 20% of the economy off the table when you're wanting to do a bill that involves big spending and big tax cuts, and you want to pay for part of it. It inevitably became part of it. So after all of that, we ended up with whatever you want to call it. If you want to call it HR 1 or OB3 or OBBBA, I never know how many B's to put in the middle there, or the big beautiful bill. Some of the opponents on the political realm are calling it the big bad bill. I'll probably stick with HR 1 to keep it safe here. So sort of what is next? We're going to have a great conversation today with two awesome speakers about how this is playing out in Illinois. And I think we're going to focus on the near term and the medium term, just zooming out for some perspective on how these things go in Washington. The bill will change over time. No law is passed and you just have it be exactly what it is and it's implemented exactly as written. There's always an amount of discretion for the Secretary of Health and Human Services. There's always forces in Congress. The midterms, they're not that far away. This bill is not resoundingly popular. There has been, you saw over the summer, lots of conversation in town halls and things, drawing attention to the Medicaid cuts. So I think, it will play in the political realm, certainly next fall. State implementation is going to vary widely, and I'm really excited to have some conversation throughout the course of the day about what's happening in Illinois and how you all are thinking about this and how you're going to implement it. Over the course of time, unpopular provisions of bills rarely stick. So there are challenges to undoing them. I don't want to be naive that things are, all these Medicaid cuts are just going to get undone. But, you look at the Affordable Care Act, for example, there was the, quote, Cadillac tax on high-cost insurance plans that wasn't implemented. You look at the reforms that were put in place many years ago for Medicare physician payment that would have resulted in significant cuts for physicians. Congress delayed and delayed and delayed those. So there's a long history that if something is really unpopular, changes will be made over time. Advocacy is really important. It will shape the future. All of the stakeholders who come to Washington, D.C. Are going to be advocating, for the things they want to stick, for the things they want to change, and that will impact what's going to happen. And finally, there's going to be a lot of litigation on this. And so, as we've seen for a lot of things this Congress, the administration will take actions, court cases will change what can happen in the end. But obviously, HR 1 isn't the only thing happening. This is probably leans a little more negative than I like to be. I do want to close with sort of a note of hope. There are 1115 waivers. Those are still happening. The waivers that have been approved are still out there. The administration still wants to give states flexibility to try things that work in their states. There will be a return of bipartisanship on some issues at some point. Congress just can't do everything on a partisan basis. We're right now at the end of the federal fiscal year. The government needs to be funded for next year. It may be shut down tomorrow, but eventually, to get to the government being funded, it has to be bipartisan, and that is going to happen on other issues. And local communities and states have a huge impact on anything that's done at the federal level, how it plays out in their states. And this is a room full of committed, smart, innovative people. And even in this climate, I think there are still possibilities for great things happening. Just in the conversations I had last night and this morning, I am hearing amazing things that you have been doing, that you didn't just start yesterday, and that you're not going to stop tomorrow. So even in this climate, I think that there's a lot of possibility. So that's just a little bit of federal landscape. I'd like to welcome up my panelists now, and we will engage in the discussion portion of this. So if you can come on up. Verlon Johnson is the Executive Vice President and Chief Government and Corporate Affairs Officer for Essentra Health, as well as Chair of the Medicaid and CHIP Payment Access Commission, or MACPAC. And Lizzie Whitehorn is the Director of the Illinois Department of Healthcare and Family Services. So welcome.
Testing. I'm working. I'm live.
You're live.
I am.
How about me? Okay,
Yes.
There we go. All right. Good morning. Good to see you. So I did an intro that definitely does not do justice to your backgrounds and careers. So why don't we start with you just giving a little bit more context about yourself and your role. So why don't we start with you, Director Whitehorn?
Sure. Hello, everyone. Good morning. It's like a lot of bright lights and really dark out there. Well, it's really nice to be here and see some friendly faces. I'm happy to give a little background. Many of you know this, but maybe some of you don't. I am really a public servant at heart. I grew up with a dad who's a clinical psychologist. My mom was a social worker and then a high school secretary. So, it was really, public service was modeled for me and serving others. I, out of college, right out of college, went to work as special assistant to the chief of staff for then CEO Ernie Duncan at the Chicago Public Schools. Fresh out of college, little did I know what I was getting myself into, but it was a crash course in Chicago politics, education reform, but also I really fell in love with working for government and trying to figure out how to get things done and navigate through the bureaucracy to really make a difference for people who rely on government for many critical services. So I then had the opportunity to work for Governor Quinn's administration, and then really got introduced more fully to healthcare and Medicaid policy working on Governor Pritzker's first campaign. And it really was an extension of my interest in education policy, and how can kids be successful? It's not just about education; it's about a lot of things, but including having access to high quality healthcare. So, after working on healthcare policy on the campaign, I went to work in Governor Pritzker's office as first assistant deputy governor. Working really closely with Sol Flores, who many of you know, and we oversaw all of the health and human service agencies. We worked closely with DPH during COVID, and then I was there for about 5 years and then became the director at HFS in January of 2024, which is almost not even quite 2 years ago, but in government time, it feels like a long time. We've done a lot. So yeah, that's a little bit about me. And I think, if I can just say a little bit about the work we have been doing at HFS before we get into all the bad news about, what's happening at the federal level. We've done a lot. I think we've led with a governor who cares so much about healthcare and views it as a right and not a privilege. And we have worked on so many initiatives to increase access to high quality health care. I can just name a few. We started the medical debt program. We've relieved over $360 million in medical debt. We've had a really big focus on maternal health. We were the first state to cover postpartum coverage for 12 months for all women, first in the nation in Medicaid. And then, of course, we now cover doula services, lactation consultants, home visiting through Medicaid. We have awarded $200 million in healthcare transformation capital investment grants. We are, along with the Department of Insurance, about to launch the state-based marketplace, which is huge. And we are also working on how to access, how our Medicaid customers can access new and transformative gene therapies, and oversaw an advisory council with experts from across the nation giving us advice about how to do that. And we'll be starting in January to be part of the CGT access model with CMS, where they negotiated for the first time outcomes-based agreements with 2 major pharmaceutical companies, so that our customers can get these transformative treatments for sickle cell disease. So we have a lot of really good things going on that I'm very happy to talk about.
So, can you hear me okay? All right, so let's give that another round of applause. I mean, great state of Illinois for sure. So, again, I'm Verlon Johnson, and I want to say thank you for being here. I lived in the state most of my life, and yet I was never involved in this forum, so I'm really glad that I could come to it today. But I'm the Executive Vice President, as you heard, and I'm also over government and corporate affairs at Central Health. We're primarily a health IT solutions company that provides solutions to states and federal government. But I also serve as a Medicaid and CHIP Payment and Access Commission chair, which I've had the honor of doing for the last year. And hopefully, if I do my job right, I'll continue to do it for another 2 years for sure. So let's put prayer up for that for sure. So I was actually born and raised here in Chicago, in Illinois, more globally. And so I just want to say on the onset that this work is very, very important to me. I've seen really very much how central Medicaid is to the families here in not just Chicago, Cook County, but in the state of Illinois overall. And so I actually, in my early career, spent many, many years at the Centers for Medicare and Medicaid Services. I think some of you may have heard of that. Okay, yeah. So I was there. I started out my first 10 years on the Medicare program, where I did a number of great things. But essentially, when I started implementing the Medicare Modernization Act, we got into the low-income subsidy and the drug coverage. And that is where I looked over the aisle to my neighbors who were in Medicaid and said, oh my gosh, the things that you're doing and then the lives and the impact you're having, I want a piece of that. And so eventually I actually morphed over into that role where I actually was able to lead the Region 5 area for 6 states. And then eventually came and morphed into more of a national role where I had the opportunity to work for all 50 states and the territories. So again, Medicaid is very important to me. Healthcare coverage is important to me. And so it's really an honor to be here with all of you like-minded folks for sure. But I do want to get into MACPAC. So by a show of hands, how many people know what MACPAC is? Okay, so that is more than usual when I'm in a crowd. So I again feel like I'm at home today for sure. So at MACPAC, our role is really to provide Congress with nonpartisan policy and data analysis of Medicaid and CHIP program for sure. We have 17 commissioners from across the United States, and they bring their experiences, their passion, their thoughts, leadership, all of that to the particular conversation. They range from providers. We have advocates. We have former state officials, former federal officials, like myself, consultants, all the gamut of folks. And you can just imagine in that kind of a setting, the kind of ideas that are generated. And those ideas are really to make sure that we're strengthening the Medicaid and CHIP program to the best of our ability. Now, we do have a responsibility, though, of providing a report to Congress twice a year. So we have a report. Now, who knows the months we provide them? This is a test. March is the first one. And June is the second one, for sure. And so in those reports, we provide not just recommendations, which we really like to do, but also we provide briefings. Obviously, Medicaid has been a top conversation starter in all different sectors. And so we've actually been able to do things like work requirements and the finances behind it. So it's really an opportunity for us to educate not just Congress and administration, but everyone else, too, that touches the program. So our role is really advisory when you think about it. We don't set set policy, but we definitely help to shape that policy for sure. And we're always looking for insights from all of you. So again, you all passionate about healthcare, you're passionate about what's happening in your state of Illinois. And so as you see opportunities for MACPAC to dive in and think more broadly about specific issues, as you can share your experiences as providers, as advocates, as even beneficiaries, we want to hear that, because we really want to make sure our reports are as complete as possible and can really help to move the needle to really make sure Medicaid is as strong as possible. So that's MACPAC, and I am going to see all of you at our next meeting, so I will make sure that you get that information too as well.
Great, thank you both. It was really interesting to hear a little bit from each of you, particularly you can tell where your passions lie, and I always like that part of people introducing themselves. So I started the day with the elephant in the room that you sort of can't not talk about, which is HR 1. And Director Whitehorn, you talked about all of these really awesome initiatives that you're undertaking. So I'm sure that you want to continue moving forward with those. And at the same time, from the federal level, there are certain things you're going to have to do. You have to prepare for the community engagement requirements. You have to prepare for the redeterminations. So can you shed a little bit of light on how you're going to do those things? You know, how are you going to continue to prioritize what are your and the governor's initiatives at the same time dealing with the federal requirements that are coming your way?
Sure. So, you know, I think we will continue to work with the same mission in mind to serve our customers. And as we get into having to implement work requirements, you know, all the various new eligibility requirements, we are going to do so with the goal to mitigate harm as much as possible and to keep as many people covered as possible. But that's going to be real hard, and it's definitely, you know, what is in HR 1 is absolutely not in line with the vision that we have for the Medicaid program and for healthcare policy more broadly in Illinois. So it's a balancing act for sure. And I think obviously we've been talking about this a lot, and within HFS, with other leaders in state government, and I think this administration has been challenged in several ways with unprecedented events, COVID, obviously, even the migrant busing issue. We have risen to the occasion and been able to plan and I think do the work as well as anyone across the country in the face of these challenges. And so we'll have to do the same thing here. Just to give some perspective, I mean, many of you have probably heard these numbers, but I think we should continue to share. I'll share some numbers and then sort of our approach to the work. But Manat Health estimates that Illinois will lose about $52 billion in Medicaid funding over a 10-year period, which is mostly due to work requirements. And so to put that in perspective, if this helps, that's just a little bit more than our entire annual budget for HFS. We are internally estimating that between 270,000 and 500,000 Illinoisans will lose Medicaid coverage because of the work requirements, which are set to begin January 1st, 2027. That is close to 15% of our customers. And that is mostly going to be due to the administrative burden. We know most people who are on Medicaid work. We can see in our data that about 68% of our customers who are not disabled have income, which is our best proxy since we don't currently track who works. So that's why we're really going to be focused on how to make this as easy as possible for our customers. And that's based on the experiences of the couple of states that have tried to implement work requirements in the past. And then on top of the coverage loss, in the out years of this, of HR 1, the state will lose approximately $6.6 billion in federal financial participation due just to the changes in the provider tax rules. And that impacts not just the Medicaid budget, but the entire state budget, because healthcare is about 17% of the state's general funds budget. So these are the large things we're up against. And as I said, we're really trying to think about how can we mitigate harm. And that means a multifaceted approach. which means working very closely and collaboratively with other agencies at the state. So, I mean, literally from the top, from the governor's office down, we have formed, this implementation work group. I mean, it's all sort of being worked out as I speak, but we will have to work closely with the governor's office, with the Department of Human Services, who really is our partner in enrolling people in Medicaid through our integrated eligibility system, which also enrolls people in SNAP and TANF. So we work hand in hand with them, and we're going to have to think very, very creatively because there are huge impacts to SNAP in HR 1 also, and there's such a big overlap between the Medicaid and the SNAP populations here. So we're thinking about technology enhancements. How do we use AI to make these processes as easy as possible? We know that our system right now is clunky for customers, so how can we make the public-facing portal more user-friendly? But it's the state, it's government, so how do we procure these things quickly on the timetable? So these are all things we're thinking through. And then also, it's going to be a huge communications effort, something that we learned a little bit from the unwinding, and we did a lot more communicating than through many different channels than had been done previously. But we're going to need to have a really robust communication strategy to reach our customers and really partner with community-based organizations, with providers, with our MCOs, everyone who's on the ground who interacts with our customers regularly anyway, to make sure that we can implement these changes as smoothly as possible.
It's a big task.
That's a very big task for sure. But it sounds like you all are really doing some great things and thinking about it for sure. So just from a MACPAC lens and a national lens, I mean, let's just be honest, we are all still in the process of understanding HR 1. I like to call it OB3, so I'll do so from now on if that's okay. States are really carefully reviewing their programs, the impact of of what will actually happen with this. And I will be honest in talking to my former CMS colleagues, and it's very clear too that they're actively trying to understand where guidance is needed and to provide that clarity as quickly as possible. But if we step back, though, I mean, this is not new in terms of states having to really think about their programs and the impact that federal budgets may have on it, right? Historically, when we think about states and the budgets have been constrained, or states have often relied on kind of three different levers. Eligibility, narrowing their eligibility is one, cutting services is another, and lowering provider rates. All, things that, we don't really want to do, right? And the director's saying absolutely not, right, for sure. And so when you look at HR 1, then you see that can add some other complexity to it as well in terms of the intersection with managed care contracts and program integrity requirements too. But the details, though, of how these things, the levers will really be used by states is really unknown until we really figure out a little bit more around that guidance that's there. So from MACPAC's perspective, what matters most is, again, how states are thinking about this and implementing this, and how CMS will implement the requirements too. So whether they can support coverage stability, minimize administrative burden, which is, I think, very key for most states as well, and maintaining access for vulnerable populations. And let me just say that again, maintaining access for vulnerable populations is going to be very important. And so that means that we're going to really, as a MACPAC body, make sure that we are tracking what states are doing for sure. We're going to analyze the outcomes that come from that, and we want to provide Congress with some real-time evidence-based insights as to what's evolving around this. And so that's going to be really our stance on this. And so we're really going to make sure that we're talking to states and really hearing more about what their pain points are as we go through this for sure.
maybe I'll switch gears a little bit. Still about HR 1, but something that's maybe a bright spot here. So for those of you that followed the legislative drama this summer, there were a number of senators from rural states that started to hear about the Medicaid impacts and were worried about rural hospital closures. And so one of the things that Congress put in the bill in the end was the Rural Health Transformation Fund. Half of the money is allocated to every state that applies, and the other half you sort of have to compete for Hunger Games for the extra money. And in this moment of money going away, everybody wants a piece of that. What can you share with us, Director Whitehorn, about what the state is thinking of? The applications just came out open from CMS. It's an incredibly quick timeline on the normal federal scale, so they put it out really quickly, and they're mandated to award the money by the end of the year. So for anyone that's done federal grant cycles, this is like lightning speed. So you guys have a huge task to put together a compelling case, and I'm assuming we'll want to go for more than just that sort of mandatory pot of money. So what can you tell us about it, and how can the stakeholders in this room engage in the process?
Sure. So just to put it in perspective, yes, it's $50 billion for rural health, which is huge, and we are absolutely going to put every effort into getting as much of that funding as possible for Illinois. But I did also want to just share that there has been analysis, obviously a lot of analysis of the impact of HR 1. And so KFF put out an analysis that said HR 1, the impact on rural health providers could be a loss as much as $137 billion. So while $50 billion is definitely a lot, it's a third of the overall loss to the rural communities. But as I said, we are working as hard as we can to get as much of this money as possible. So many of you may know we, even before the application came out, because we knew it would be a very quick turnaround, we have been meeting with stakeholders who represent rural healthcare providers, other types of healthcare advocacy groups. We held a virtual listening session a couple of weeks ago. We had an online portal open to receive written feedback, and I think received close to 100 submissions from various people and groups. So we're using all of that input as we shape our application. The application did come out, and it's pretty prescriptive, I will say. I mean, as you said, the first half of the money is divvied up among states who have like a completed application. I mean, it's not that high of a bar. But then the second half, there's all sorts of qualifications that relate to some factors that we cannot control, about population size and things like that. And then the rest of it is how we choose to propose using the money and how that fits with what CMS has put out. I think CMS is broadly focused on 5 areas: preventative health and addressing chronic disease, supporting sustainability of healthcare networks, workforce development, value-based care, and consumer technology and IT advances. And those are a lot of the themes that we've heard so far from stakeholder groups. I would add probably there's been a fair amount of discussion on access to behavioral health in rural areas also. So we're working really hard now to put together the best application that we can. And I think the other thing that is always on our minds too is it's 5 years of funding. So how do we make this meaningful and move the ball forward, but we don't set ourselves up for a funding cliff when that funding ends?
I just want to, just say I think the things that you are doing is great, right? It really makes a lot of sense in terms of really figuring out how to obtain those that funding for that. One of the things that we are really thinking about at MacPac is that we've kind of been a little bit down this road a little bit from the ARPA funding, right, and how that is expiring. And we are really trying to think about what are the lessons learned there, so that when Congress and administration has this windfall of great opportunity. That's what I will say. How do we make sure that they're doing it the right way, right? And so we'll be also following what's happening with this one too as well, and we can hopefully make some recommendations to Congress about how they can maybe do it a little bit differently or make it a little bit more palatable and easier for states and others.
That's great. I'm going to ask one more question, and then I do want to leave room for some questions from the audience because I'm sure there are lots of things that you want to ask. So put on your thinking caps for our last few minutes. But Verlon, we've talked a lot about Medicaid today for obvious reasons, but I know the duals population, dually eligible for Medicare and Medicaid, is certainly a focus of yours, and particularly at risk in this moment. Can you sort of talk about how you're thinking about that population from either wearing your MacPac hat or any of your many other healthcare hats that you wear?
I am one of the few people that's worked in Medicare and Medicaid, probably. But when we think about the duals population, and we realize there are 12 million people who are dually eligible for Medicaid, and we also know they are the most complex needs as well, right? And so that means that they experience the most fragmented care. And so I think from numbers perspective, I think that's a third of the population of Medicare spending and 30% of Medicaid spending. Medicaid spending is what you see from that perspective. And so, as you said, the risks are pretty clear when you think about that population. It means that Medicare and Medicaid really needs to be aligned because care can be not only fragmented, but costs can definitely shift between programs. And when all of those things happen, then you see disparities get worse, right? And so duals then are most likely to be Black or Hispanic, which also means that you see definitely some other gaps as well, some equity gaps as well. But there are opportunities that we are gleaming in on when we think about this population. Many of you know that the Medicare and Medicaid plans, or the MMPs, are phasing out, and there are the DSNPs, particularly those fully integrated DSNPs, and they are now the primary vehicle for states to align those benefits. So states can actually use their state Medicaid agency contracts or SMACs. You ever wonder, why in the duals we have these great acronyms, right? Yes, SMACs, right? Yes, for SMACs. To really require a more integrated member materials, that single ID that's needed, more unified appeals and grievances, data reporting, of course, on care coordination and outcomes. And so with those contracting levers that are used that states can have, they can really make sure those programs are more integrated. And we're doing all this from a MacPac perspective because we've heard directly from beneficiaries. I mean, just like all of you want things streamlined, right? I mean, you don't want to have multiple channels to do things that you can do one particular way. So they actually value, of course, having care coordination. They like seamless transitions. I mean, who doesn't like a seamless transition, right? And even supplemental supports like maybe food and transportation is important to them as well. And so from our perspective at MacPac, our long-term vision is really to make sure that all duals, and not just a portion of the duals, not just half of the duals, but all duals have access to integrated care. And we've recommended many different opportunities for states and CMS to really lean in on that and to make sure that these are opportunities for all duals that are in existence. So duals are very important for sure.
Yeah, thanks for mentioning that. Really important and not always thought of population. Okay, let's take a few questions from the audience. We have a little bit of time. So hard for me to see with the bright lights out there. Okay, I definitely cannot see where you are, but okay.
Get a waiver, or does CMS articulate what the waiver to delay the work requirement implementation might look like? Any feedback from them yet?
So I think this was a few weeks ago now. Dr. Oz, I believe, made very clear that CMS is disinclined to grant any waivers to any states for the work requirements. So we're moving forward. We have to move forward to plan for this to start to be implemented on January 1st, 2027. And I think, as you said, CMS, there's a lot of guidance that CMS has to put out. And we're planning as much as we can without it. But we ask frequently. There's a lot of various associations who are talking to CMS and giving them feedback too. So, we'll see what comes out if they put guidance out about how to apply for a waiver, if we think we should apply even though we've heard that they're not inclined to grant it. But regardless, we have to plan as if we need to implement work requirements on January 1st, 2027.
I think the question wasn't for me, but I'm going to go ahead and answer just to offer a little perspective. So part of the reason I didn't really tell you anything about me, but part of the reason I was asked to be here today is I am not an Illinoisan, but I did work for Senator Durbin during the period when the Affordable Care Act was being passed, and then at the Department of Health and Human Services afterwards in that implementation period. And I think from a state perspective, it is very wise. You can never plan that something is going to go away. But, my job when I was at HHS was working sort of the Secretary's legislative advisor. And let me tell you, the representatives and senators from all across the country are going to be hearing from their states about the challenges that they're facing. And those matter. They don't like taking those calls when they're secretary. And it's going to take some time. You can't yet forecast some of the problems that you're going to encounter. Neither can some of the other states. But it's going to make, the associations you're part of, the National Governor Association, the, state ASTO, all of those kinds of organizations really important, because you really need to raise up when you're facing these issues. They're going to come up. You can never anticipate all of the challenges in implementing something so complex. So don't count on it, but certainly make your voice heard when it's time, as you're getting closer and you're hitting road bumps that you didn't expect.
Yeah, and I was going to say, and as a former CMSer, we don't know everything. Yeah. And so I would say, I think I was with, is Emma here as well? I think she did a great presentation yesterday at the county thing. But when we're talking about different definitions, right, around fragmented, elderly, and things like that, you define it, and then have CMS tell you, no.
Yeah, no, I think that's what we have to do. We're going to move forward and plan and come up with where there's wiggle room or lack of clarity, what works for us. And two things I was just going to add. One is, we work closely with CMS, and at the staff level, and people are trying as hard as they can to support the states and move work along. They are also suffering from lack of staff, lack of resources, people having left, and we see that even in our interactions with CMS. Secondly, your point here, advocacy will shape the future. I do want to say, we have time. Some of these things, especially the provider tax changes, the state-directed payment changes, they're not supposed to take effect for several years. So I absolutely think we have to keep advocating and talking about the impacts. And, I'm an optimistic person. There's still a possibility that some of this could change. And we have to plan in case it doesn't, so.
Are there other questions in the crowd?
Yeah, I have a question for Chair Johnson, and the question is one of semantics and language. We've heard in the run-up to HR1 the concept of vulnerable people, and we have to preserve Medicaid for vulnerable people. And it seems like that's code language. It means, again, back to women and children. And we know historically, when the ACA was installed, and we saw unbelievable amounts of disease coming out of the woodwork, untapped utilization, both on the clinical side and on the mental health side. And so I wonder if you can comment a little bit on the language that's being used in Congress about who actually is a vulnerable population.
Yeah, I think you're right. I think that it's not necessarily as clear for everyone, but when we think about vulnerable population, we are thinking about marginalized communities. We are thinking about people who, when you think about things like social determinants of health, where are the levers there that's pulling on them for sure? We're thinking about people who are frail, potentially because of health issues. They're not getting the right health outcomes. So it really is, if I think about, how do I say this in a nice way? You think about a totally, completely healthy person, right? It's not that person necessarily, right? It could be that person if they didn't have the resources that they needed in order to get their support. So I think that's probably a longer conversation, but in terms of how we're thinking about it, it really is traditionally marginalized communities. We're thinking about from a financial perspective. We're thinking about from a from the SDOH's perspective. I think that's how we're looking at it right now. But Jay, I'm sure we'll have more conversations around that for sure.
We have, unfortunately, not that much time left. I feel like we could go all day. So I want to close with a thought from each of you. This is sort of the Illinois healthcare powerhouse, brain trust out here. These are all the people you all work with, the leaders in the state, the doers in the state. What's one thing that you would advise them, something you want to know from them, something they can do for you, something they can work with you on? What's the sort of advice or thing that you would like to talk with all of these great folks in the room about?
Okay, well, I mean, there's probably many things I would want to talk to people about, but I think, as I said, this is going to, and it's quite obvious, everyone knows this, implementing HR1 is going to be extraordinarily difficult for the state, but also, I mean, it reverberates down to providers, and those who work closely with the customers and our customers. So, I think we need creativity, and now is the time to put any idea on the table. That crazy idea you've thought about and you thought, oh no, we can't do that, or, I think that's where we are and how we need to be thinking about this, whatever your piece of working with the Medicaid program is. So we're open to any and all ideas and be creative.
Yeah, that's a really great one. I will say that the challenges are obviously real, right? But I really want to believe the opportunities are there too as well. And so I do believe if we can focus on evidence, right? We've seen work requirements work and not work, right? To extent. So why reinvent the wheel, right? We want to make sure that we're thinking about accountability, right? So as we think about the fact that I know we have plans out there, 3/4 of Medicare beneficiaries are enrolled in plans. How, as a plan, can you make sure that you're accountable, and how can states help you to be accountable, right? So that accountability piece is there for sure. And then the last one is fairness, all right? Otherwise known in this greatest of Illinois, we can say equity here, right? And so when we think about those key things, evidence, when we think about accountability and fairness, I think if you all can help us make sure we have those three things, I think that we can do all the great things that the director here talked about for sure.
Thank you both. I feel like it is a challenging time. There's no denying it, but you've given some great hope for what we can do together and how we can make the best out of this situation, and how we can keep driving forward some of your important priorities. So thank you.
Thank you.
Thank you.